the new curriculum gave importance to testing the knowledge in context. And that is especially true for competency-based medical education. The interest in scenario-based MCQs has actually gone up. More and more medical teachers are trying to create MCQs which do not simply test recall of facts, but which test the application of knowledge, interpretation of knowledge, diagnosis making, therapeutic planning, and so many other things. At the same time, the recent events which happened surrounding the NEET, where we saw issues of paper leakage and students trying to use various unfair means, then that adds another dimension to the possibility of a MCQ test. And as I was preparing for this presentation today, which is primarily aimed for the PhD students who are doing a doctor's degree in health professions education. But we thought that even others can also benefit from it. And so we opened it to anybody and everybody who wanted to join this program. Now, when I was preparing, in fact, what attracted my attention was that on a parallel side, on the internet, you can actually have a lot of information, maybe right, maybe wrong, on how to crack any MCQ examination. And many things like negative marking and giving differential marks, etc., can create much problem in spite of the number of questions and quality of questions. So when you write a MCQ, you have to be very clear that you do not give space to the student, exploit the weaknesses in writing, planning, or presenting the MCQs. And in fact, many of the books which I downloaded, and if you want to, please get this book, Rock, Brick, Scissors. It's freely available on the net. It's a PDF format, and it tells you how to crack an MCQ. Now, I do not want to promote unethical clearing of MCQs, but what I'm trying to emphasize is that if you are aware of the weaknesses in your writing, if you are aware of the ways where students exploit the weaknesses in MCQs, then you can actually take care of them to frame better quality MCQs. Rule of thumb, if I say, is that writing scenario-based MCQ is no reason to bypass the general principles of writing good MCQs. Now, in this particular session, because of the lack of time, we'll not go on to writing good quality MCQs. There are a lot of materials available, a lot of papers, publications, textbook chapters, and so on. You could possibly go through some of them to look at what are the qualities and what are the principles of framing good quality MCQs. But what I want to say here is that all of us have actually used a zoom lens and a normal lens. When we had old mobile phones, it was just 5 megapixels, no zoom facility, etc. It was so easy to click a picture. You just aim at something and click, and you had a good picture. But now, with optical zoom coming in, where you could even zoom up to say 4x or 10x, then it becomes very important that your hands don't shake. Because then the chances of getting a blurred picture is very high contrasted to a normal picture. And I think something similar happens with MCQs and scenario-based MCQs. When you have simple MCQs, they are easy to write, easy to score, easy to administer. Although they do not test what we want to actually test. But when you have scenario-based MCQs, they test what you want to test. But they are difficult to frame, difficult to administer, difficult to mark, and difficult to quantify. So that is the dilemma that a medical teacher is faced with. Take, for example, one parameter, and that is guessing. Now, if you have a simple question like this, the mandibular nerve, Now, guessing becomes very difficult in this type of question. Random guessing. I'm not saying of intelligent guessing, where you can eliminate some things, where you can do some manipulation of knowledge. But random guessing becomes very difficult in these kind of questions. But if you frame a scenario-based MCQ like this, then what you would find that guessing becomes very easy. And I'm sure some of you have already picked up the correct answer based on the way the information is presented in the STEM. Now, that is one thing which one has to be very careful about. Because if you're not careful about ensuring that you do not give away the answer on the platter to the student, then you have to really work a little extra and a little hard to make sure that the MCQs do not become a prey to easy guessing. So when we talk of purpose of assessment, basically we talk of three things, that is assessment of learning, assessment for learning, and assessment as learning. Of learning means that summative examination, find out how much the student has learned. For learning, when you use assessment to promote good reading habits and good learning in the student. And third, which is actually picking up very fast, is using assessment task as a tool for learning. As a very broad example, if I say you do not take a lecture, just give a task to the student. You go to a village, you find very high prevalence of anemia and malnutrition. What will you do to improve the quality? Now, these kind of things can't be answered by reading a book. They have to be answered by actually going through the task and seeing the actual condition. So this assessment of learning actually is getting only pushed to the selection and certification type of examination. For most others, we actually favor using assessment for learning and assessment as learning. And MCQs, whether we like it or not, have unfortunately become the primary mode of learning in the PPG examination because the entire career of the student depends on one examination. So he is more interested in learn about MCQ than learning about the disease process. And it's not unusual. You go to your college cafeteria, you go to your college library, you go to some revision room in the boys' hostel and girls' hostel, and you will find everybody sitting with the MCQ book trying to memorize the answers to those MCQs. Now, that actually defeats the very purpose. You should actually write an MCQ which cannot be answered by reading it. Then only you will succeed in using MCQs for the real purpose that they are intended to serve. Now, when we look at the uses of MCQ, traditionally we are using it for testing factual knowledge. So length of some organ, for example, is 3 centimeter, 4 centimeter, 5 centimeter. So that is the classical way you would use an MCQ to test factual knowledge. But the second way which you can use is actually incorporation of layered scenarios. And please note the keyword that I have used, layered scenarios. That means you may not reveal everything at one go. You gradually really reveal things. So you come with history, for example, and next you may reveal investigations, and then you may reveal about radiological findings and so on. And what is more important is that there can be actually two formats. One is stimulus format, that is what and how you ask. And second is response format, what and how the students answer. If you reflect on the MCQs that we have been grown up with, most of them are actually response format. So like I gave you that example, mandibular nerve is. You didn't pose any challenging task to the student. But learning is much better with stimulus format. How you ask becomes more important than what you ask. And if you go on the Bloom's taxonomy of learning, then what we find is that most MCQs actually target only the lower two levels, that is remembering, understanding. But if you write scenario-based MCQs, you can actually move to the highest level, except creating. I mean, that's something which you, as of now, cannot test with MCQs. Maybe we'll might come out with new formats sometimes later, and then it should be possible. But definitely applying, analyzing, evaluating. Now, these are certain things which you can test with scenario-based MCQs. So please keep that in mind. And why students are able to exploit MCQs? Because of the item flaws. Before you get any depressing feeling or before you get a guilt feeling about not being able to write good quality MCQ, let me tell you that the word index of flawed items is something like 37 to 72%. So, in other words, almost three-fourths of the items produced in even very good institutions might be flawed and would need modification or change or sometimes even discarding them. It's common, it happens. So, approach MCQ writing with this perspective. It's not that in first instance you will produce a perfect MCQ. You will. There will be flaws, there will be issues, there will be problems. But that is where your peer group actually chips in. Give it to them. Ask them to comment. Ask them to point out what are the mistakes and what are the problems with these kind of MCQs. This can have both negative and positive side effects. Now, if you are making it easy to guess, that's a negative effect. A student who doesn't deserve to pass will pass. Or sometimes what happens is your options may be so complicated that even good quality students are not able to pick those right answers. And as a general rule, what you should keep in mind is that it is always the high performing the students who are affected more by a flawed item as compared to low performing students. Very common example. You the question, what is the boiling point of water? And you say 50, 98, 75, 200. Now, a low performing student would easily pick 98. He doesn't differentiate anything. A highly performing student, who will get, oh, they are not written centigrade and they are not written Fahrenheit. It cannot be 98, but 200 is more close to 212 degree Fahrenheit. So he'll pick. He has more knowledge, but he gets penalized for it. And that actually becomes completely unfair to a high ability student. And that is what we have to avoid. Two of the most common categories of problems, because you can put almost all the problems into one of these two categories. One is test wiseness. That means you become wiser in taking a test. But mind you, it is only taking a test, not knowledge. Only how to take the test, you become wiser. So I'm told that when they go to coaching classes, one of the things that they are taught is how to crack a question. And notice the word. They don't say how to answer a question. They say how to crack a question. Even for other examinations, G and IIT, etc., etc., they talk of cracking the exam. They don't talk of answering or getting the exam right. So grammatical clues can be a big issue. Absolute terms, long answers, and I'll give you a few examples as we move through the presentation. Something which is called slang association. Can I request all the participants to please mute themselves? Can you please mute yourself? There are some background noises coming. Thank you. And there is what is called convergence strategy. I'll give you some examples. And second is irrelevant difficulty. And this actually stems from the mindset of item writer. In one of the workshops that I was conducting for MCQ writing, one professor in medicine, she wrote a very funny kind of MCQ. So I asked her, ma'am, this is not the right way. You are confusing the student. And her response was really classic. She says, sir, जब तक student confuse ही नहीं हुआ तब तक मजा क्या है? You know, purpose is not to confuse the student. So don't create a question to confuse. Create a question to find out the level of knowledge, the degree of knowledge the student has acquired. The use of vague terms, non-parallel language, none of the above, all of the above. We'll come to some of these as examples when we proceed further. Now, one of the best ways to answer MCQs is to identify the key. You can do it by two ways. One, if you know the answer. But if you don't know the answer, you can still guess. And what helps you to guess? First, that correct answer is always longer than the distractors. Many years ago, I was having a discussion on MCQs with my head of the department. I was only a lecturer, assistant professor equivalent that time. And she was saying, oh, we don't write good MCQs. And look at USA, how beautiful they write. And I brought this book from USA. So she was sitting just across the table reading that book. I was sitting on the other side of the table, not able to read the question. But from there only, I pointed, this is the right answer, this is the right answer. Oh, how did you find out? The longest answer which is visible is the right answer. And for most of the students, this trick works. Second, when you are using textbook wordings, and a student who has read the book would identify the wordings which were used in the textbook, and therefore he would pick that as the correct answer. Third, when you use always, never in the correct answer, but you don't use in the distractors. And then with distractors, when correct answer and distractors are not homogeneous in content. One talks of treatment, another talks of prognosis. Then you know there is a issue somewhere, and you try to identify that issue. The grammaticals sometimes can give you a clue, like A and N. If your option is starting with the vowel, you can pick it up because of A or N use. And again, converse to what we said here, the distractors are generally shorter in length as compared to the correct answers. Now, I talked about the stimulus format and response format. And in fact, to me, this remains one of the biggest guidelines for the item writers. Always focus on the stimulus, how you ask. Now, look at this question. What are we doing? We are not interested in the stimulus because that is a very general, vague kind of thing, which is the most important mechanism of heart failure. And then we give 4 options, out of which the student will pick one. So this is the classical example of response format. But if you were to add a history to this, and mind it, your options still remain the same. Options have not changed. So your response has not changed. Your stimulus has changed. So now what will happen? The student has to read the question, analyze the information which is being given, come out with the differential diagnosis, and then pick what would be the right answer to this question. You would also notice that earlier trend was to have a short stem, like remember that mandibular nerve is finished. So a short stem and a long answer. Now the trend is reversed. Now you have a long stem and short options and distractors. It is because you want to focus on the stimulus, how you are asking that, what information you are providing to the student to interact with, analyze, and then come out with an answer. Australian Medical Council, which are involved with the certification and can we mute everybody? Yeah. No, when they are looking at the purpose of MCQ, And I have underlined some of the important words. So it focuses on basic and applied. So it's not just recall of knowledge, it's application of knowledge across a wide range of topics. That is an inbuilt advantage of MCQ, that you can sample a wider content area as contrasted to essay questions or short answer questions. There, you are testing the understanding of the disease process. You are testing the ability of the student to interpret the clinical examination, diagnosis, investigations, therapy, management, and more importantly, the ability of the student to exercise discrimination, judgment, and reasoning in distinguishing between the correct diagnosis and plausible alternatives. So the ability to make a good differential diagnosis and pick up the correct diagnosis of the multiple differentials that you generate can be actually exploited by framing good quality MCQs. Please keep that in mind. So it is not just a recall, but you can use MCQ as a teaching aid. And the term that I used earlier, that is assessment as learning. Now that is where MCQs can actually help you. If we compare the conventional MCQs with scenario based or case based, in fact, scenario based nomenclature is typical for India. World over, generally, they say case based. So many places in my presentation, you might find a difference between scenario and case based, but basically, I'm talking about the same thing. The recall type of questions, they may be useful. It's not that they are useless. They may be useful for assessing the efficacy of your teaching. You're given a lecture, you want to find out if the students have really picked up some points. So dose of this drug, so many milligrams, you can test by recall question. The major pathological change in such a disease, you can test by recall type of questions. At the same time, they can be used as a rapid fire stimulation for learning, because scenario based or case based questions will need time to read, understand, then answer. Whereas in recall type of questions, that is not a problem. And you can use these attention keeping strategy. While you are taking a lecture, in between you project an MCQ, ask the student to answer and respond by WhatsApp or Google Forms or whatever. The case based actually are basically for problem based learning, problem solving, promoting clinical correlation, promoting application of knowledge, and promoting clinical decision making. So if you look at the qualities of IMG that we have given for ourselves, then what you will find is that many of these things can actually be promoted and addressed by a well written multiple choice question. The case based MCQs offer a lot of other advantages. That is, they integrate theory and practice in addition to testing higher order knowledge. They embrace contemporary pedagogy. That is, not just feeding raw data, rather promoting the students, engaging the students, encouraging them to analyze the data that you have provided them and come out with a diagnosis. It enhances the proficiency in differential diagnosis. I gave you some examples. In the next few slides, you will see some more examples of how you can actually promote the ability to make a good differential diagnosis. Take this example. Pure and simple recall. It doesn't require any reading, interpretation, analysis on the part of the student. You have to simply know nephrotic syndrome, normal renal function, what is the correct one. And in fact, if you go by the STEM, then children normal renal function actually gives you a clue that you are only talking of minimal change nephrotic syndrome and not of others which appear more complicated and more serious. But what I wanted to point out here is that the discrimination index of this question is only 0.01. Now, when you do an item analysis and look at the ability of the MCQ to discriminate between a good and not so good student, then it is only 0.01, or which will translated other word would mean only 1%. You add a scenario and your options remain the same. You have not changed your options. Simply added the scenario. Now, by adding the scenario, your discrimination index becomes 0.16. So 15 times jump in the discriminating ability. So they are a better judge and a better discriminator of good and not so good students. So just looking at marks in the raw MCQs does not give you a correct picture. And even more interesting, that if you increase the length of the scenario, that means you add more facets into it, more information, more data to be analyzed, more things to be looked at. Then the discrimination index can jump up to 0.32. So imagine from 0.01, you have made a 32%, 32 times jump, 320% jump in getting a good discrimination index. And these come out from the data of National Board of Medical Examiners, USA, where they have actually analyzed these questions based on no stem, short stem, and a long stem. Holland and Neal, two of the well-known authorities in formation of scenario-based MCQs, recommend that single best answer items, that is what we commonly use, that where there is only one correct answer. So single best answers should include a contextual vignette, another term for scenario or case that you use, a clearly defined, positively phrased question, what is called lead in MCQ terminology, and 5 homogeneous, concise options, one of which is clearly identifiable as the single best answer. Now, they have recommended 5 options. We are traditionally using 4. In fact, it is really difficult. From practical experience, I can tell you, really difficult to write an MCQ with 5 options. So, two of our good friends, Dr. Avinash Supe and Dr. Rashmi Vyas, they actually analyzed the literature and they came out with a consistent reporting across the world that even 3 choices are good enough provided they are well written. They don't simply increase the chances of guessing. On the other hand, by writing 5 options, you actually increase the chances of getting, because then you tend to put things which are not really relevant to that. Second thing which you probably would have noticed is that we are talking of a single best answer. We are not talking of the single correct answer, because you are using it in a clinical setting. So there can be more than, might be more than one correct answer. Now, it is up to you to make sure that the second correct answer, if at all, is quite far away from the best answer, so that the students don't get confused. I'll come back to this point a little later. Now, why do these problems arise generally? Is because there is a mismatch between the way we write items and the way the students approach a item. How do we write an item as an examiner? Think of a concept and tell me at the end of it, did you identify it or are you doing it any differently? Not that it's a wrong way or there is any problem with it. That's what most examiners would do. So identify an area, content, problem, topic where you have to write an MCQ. Then you write the stem and you pose a straight question. What is the diagnosis? What would be the dose? What would be the prognosis or whatever? Then you write the correct answer and provide as much information to make it correct. Because you have to say single best answer. It has to be the best answer. So you add more and more and more to it. So it becomes longer, it becomes verbose, it becomes loaded with textbook words. And then you think of distractors. And how do we create distractors? We try to take something off or add something to the right answer and try to create a distractor. There also, creating first distractor is easy, maybe. Second is slightly problematic. Third, almost impossible. So by the time you reach the third, you are at none of the above, all of the above, because you have to complete the fourth. So that is generally the way we write MCQs. But if we look at, I see some raised hands, we will answer at the end of it. Dr. Veerbhadram will answer all queries at the end of it. Okay. So can you please now look at the way the students answer this question. How do they answer? They would read the STEM and, and try to understand. Then can I, can I request all the participants to please mute themselves? And please remember that in our minds, the knowledge organization is around concepts. I'll tell you what I mean by this. In our mind, the knowledge is stored in the form of schema. You saw a case, you heard the history, you looked at the physical examination, you looked at the investigations. So that whole thing got stored into one schema in your mind. And now what the student has to do is to quickly scan the schema in his or her mind and then come out with an answer. So what it means that the moment the student reads your STEM, the correct answer should flash in his mind. And all that he has to do is to compare that correct option with the four options that you have provided and decide which is the correct answer. That is what would typically happen when you are trying to answer a MCQ test. Please also remember, and this is in fact something which we tend to forget when we design an MCQ test, and that is that students have only one mind irrespective of the number of subjects. So you cannot say that the answer to this question would be different if it is asked in community medicine department, and the answer would be different if it is asked by the pediatrics department. Immunization schedule, for example. There was a time when both the departments followed different kind of schedules. So the students would get confused which answer they should pick, pediatric answer or community medicine. That is not the right thing to do because the mind is the one and they would store the answer as a concept, not as pediatric answer and community medicine answer. Contrast this with a case-based or scenario-based question. Now here, how the students answer? You provide them with a brief scenario, vignette, case, whatever you call it, to simulate a clinical scenario. The student has to make a diagnosis based on the information provided and then select appropriate intervention and prognosis, whatever task you have given. So it's a two-step process. So first you have to analyze, come to a diagnosis, and then you have to select the appropriate answer. And please remember, when you write a scenario-based MCQ, you have to follow this sequence exactly. What happens most of the times is that we downplay this part. We either provide the information which is complete in itself, so that the student doesn't have to do anything, or we provide an information which doesn't have enough findings for the student to make a diagnosis. Now, the purpose is lost in both cases. So, when you write an MCQ, please make sure that the student needs to first interpret, analyze, understand, and then answer your question, because that would be the true use of a scenario-based MCQs. There are many challenges which can happen.
Yeah.
You can still put over-reliance on recall because that is the easiest. Remember that question, manipular nervous? Write that and then write four isolated, unrelated facts. Easiest to settle. Or there could be misleading distractors when examiners try to sometimes deliberately confuse, sometimes it happens inadvertently. Then the lack of STEM clarity. You have not provided a clear direction to the student. Sometimes there is an over-reliance on single best answer. And sometimes you offer very limited options. You're not giving the full spectrum of the disease as a possible option from which the student has to choose. Take, for example, this scenario. My pharmacology friends, and I apologize right in the beginning, not to criticize any department or any item, but just to use it in the example. Now, if you have a scenario you want to teach the student that what happens when the patient fails to respond to oral. So I looked at one of the books of MCQs related to pharmacology and picked up questions related to that. One question, and correct answer is she might be taking antacids because
Yes.
that is what they
एक
included in the
second, huh?
answer. And these are some of the themes I identified, taken with antacid, taken with meal irrigation.
जूता पहन
Now what will happen? The student will go with the idea that if a patient fails to respond
के
to iron, the whole
इसमें
problem
सेरेमनी
will be
कहाँ स्पेशल
the
थ्री
way you have
नाइनटी एट पेज
administered iron,
देखिए मैं
nothing else. Nothing else needs to be done.
ये कौन सी टॉपिक
But as a clinician,
क्या चाहिए
when
थी
I have a
पढ़ने
child
है
who doesn't respond to oral iron given for 3 months, I would be worried.
जब सिस्टम पक्का
Have I
है
needed
बहुत पुराना जब मैं ज्वाइन किया था फिर इस पे
there
पीपल
in blood
सॉल्व
loss, some worm infestation, some mucus diverticulum, some hemorrhoids from where he keeps on losing blood more
लैंग्वेज
than what
कैसे
he
है
formed
पता
by
नहीं
your iron, malabsorption,
मैं भी अच्छा है
malignancy,
फर्स्ट ईयर में
congenital
लेंडर भी देखना था
aplasia, or thalassemia.
मतलब बी
So
एन
Excuse me,
now
sir.
you cannot
Excuse me, sir.
simply
Sir,
say,
excuse me. Dr. Momi Barua is disturbing.
इम्यूनिटी ना
Ma'am, Momi Barua. Dr. Momi Barua, please can you mute yourself, ma'am? It's very much disturbing the other audience.
somebody is still, put the mic on.
Yeah,
Please,
it's Dr. Momi. Momi Barua. I'm sorry.
thank you. Thank you so much.
है ना
So
वहाँ से स्टार्ट 398 बनेगा तो इधर
when you are,
डब्ल्यूबीसी से स्टार्ट होगा ना वहाँ से पूरा वहाँ पे
so when you are looking at the questions, you cannot have a question that this will be okay for pharmacology, this will
ट्राई
be okay
करना
for.
होगा तो इधर से पढ़ना
Please remember, student has
लगा
only one.
लगा से
If you teach him all that, next time with a patient also, he'll do the same thing. He will not look at other causes which are probably far more important. And if only I have ruled out continuing blood loss, I have ruled out a malignancy, I have ruled out a congenital disorder causing anemia, then I would think, okay, is it that he is not taking iron or it? So the perceptives differ. And therefore, if you are writing a scenario-based MCQs, it's a good idea to always involve your clinical colleagues to look at the correctness of the responses and what a clinician would generally do in those kind. Because please remember, the purpose of whole medical education is to make the student a good clinician who can go out and serve the community. We are not trying to create a basic scientist or a pharmacologist or a physiologist or a pathologist. So focus on the clinical aspect. And for that, the best way to do is to get your clinical colleagues into it so that you can really get what possible situations are likely to be encountered in clinical practice. Take another example. This was about nitroglycerin. Somehow, most such questions are coming from pharmacology. Not that they said bad questions, but because they're so eye-catching that it's easy to pick them up. Anything odd you find in this case? patient comes to the emergency and within 10 minutes, he collapses. I am not worried about sildenafil taken the previous night. I am worried about, has he got a massive MI? That is what I need to rule out. But what happens is, once you give and keep on repeatedly giving these kind of questions to the students, they go with this idea that, okay, if sildenafil and nitroglycerin, he can collapse, no problem. So this is where we can actually convey wrong information to the student by not really framing a good quality vignette, scenario, or case. Now, what are the guidelines for writing good scenario-based questions? One, that they should test application of knowledge to. Second, they should focus on common or potentially catastrophic problems. See, when you have a selection test, NEET, for example, pre-PG exam, for example, there you might put questions which they are unlikely to have seen in their lifetime. Some rare syndrome of leukemia with some chromosome analysis, with some anomaly. Okay, because you are trying to pick the best out of the whole lot. But for your formative and internal assessment process, you cannot afford to do that. You should be focusing only on common problems. Avoid zebras. There are so many situations. What will you do? Some clinician might say, I'll operate, and somebody might say, I'll wait and watch. Don't have a scenario like that. Where senior clinicians don't agree. How do you expect the students to agree? Not possible. Then, any scenario where a specialist is required should preferably be not given. Because they have a different way of looking at things. They have a different way of thinking, which you cannot expect from a graduate medical student. And focus on the common clinical reasoning mistakes. What mistakes students commonly make? In the previous question, they may say it is because of a concomitant cell NFL that he collapsed. It's a common mistake. So you should be focusing on the real issues which might be life-saving. He can keep this patient under observation without doing anything and let the patient die. Or he can think of a acute severe MI and take interventions and measures to save this patient. Now, how do you generate? First is obviously decide the topic. Second is to develop the case. And case development can have two sources. One, it can come from authentic situations. You have seen a patient, you had an interesting case, the students presented a case, the students saw a case in the casualty. So these are some points from where you can generate cases. Second is hypothetical. You can sit in your office and then write a case scenario. Both have their own advantages and disadvantages. If you are using authentic situations, then they may not be seen very commonly, and you putting that authentic situation might confuse the students. Conversely, if you put hypothetical, you may be too straightforward and textbook oriented, and you may not incorporate the variations that are seen in actual clinical practice. So you frame questions, frame distractors, and your distractor should be conceivable, coherent, and non-deceptive. Any doctor seeing that patient should think of that deceptive somewhere. And I'm sure you have already guessed it rightly that the distractors are actually the differential diagnosis that you would put in a clinical scenario. So if your main diagnosis was enteric fever, it's okay to put a distractor which suggests hepatitis, which suggests polycystitis, which suggests ileitis, but don't put something which says upper respiratory tract infection or myasthenia gravis. That would be futile because it will not really serve as a differential diagnosis. Sometimes you can use computer-generated distractors. I recently read a paper from NIPA where they used a computer program to come out with good quality distractors. Sometimes these very short answer questions where you are asking the students to write only one word or one line as an answer can actually provide you some common mistakes and misunderstandings that the students have, and they can serve as very good distractors. Authenticity of the case is one point, but then precision and clarity of language, incorporation of clinical reasoning. At the same time, they should help you to provide a good quality feedback. And this will happen only when you get good differential diagnosis into your options. And then, of course, you have to evaluate and validate the questions that you have written. So when you are writing a scenario, and I cannot stop myself from repeatedly re-emphasizing that you have to focus on important clinical problems. Don't go on rare issues. Don't go on something which is seen only once in 100 years. That is not what the student is going to go out and see. Focus on something which is very common, which he'll see 10 cases every day. That is what you should be focusing on. Don't spin around terms. Sometimes, all of us have a different interpretation. For example, frequently. There's no consistent definition. I may be thinking frequently as 70%, somebody else may think frequently as 30%. It's quite possible. So don't spin along single terms. And as a general principle, move from symptoms to findings to diagnosis. That is what exactly you would do in a clinical practice and treatment if you want to improve that. But please don't move back. And I have seen some questions. A patient has been diagnosed as XYZ. What clinical features would you expect? That's not really the kind of MCQ you would like to write for a student. Patients don't come to them with complaints like this. Doctor, I have got cholecystitis. So where I should be having pain? No, they come other way around. They say, I have pain on the right side below the ribs. What do you think I have? So don't reverse the process. Always move from your symptoms to clinical signs to treatment and diagnosis rather than going backwards. And please focus on the problem, not on your subject. Don't say in our department immunization schedule is like this, so we'll focus on that. That's probably a wrong way of, because it confuses the student. It generates more than one correct answer, and you don't know which answer the student should be picking. Sometimes asking your colleagues to write an answer to the problem, don't show the options to them. Just show the stem, ask them to give the answer. Now, sometimes that can be a very useful strategy to really test whether, remember that sequence which I told you, the student reads the question, the answer flashes in his mind. So this is what you are trying to test, that if my colleague who is an experienced pediatrician or physician or a surgeon or whatever, so when he reads this scenario, what flashes in his mind? So that is what will give you very good inputs to improve the quality. And needless to say that you should collaborate with clinical colleagues, because ultimately, whenever you have a scenario, it will be clinical. Very uncommon that you will have a scenario restricted to your own department. You can have, like, for example, pharmacology. You can have about some drug, and then you can have about, and then you can have about drug interactions and so on. You can have a scenario like that. Most of the times, it will be a clinical problem. So get your clinical colleagues into this and get their inputs as to what do they think about the history or case or regulate that you have written. This is one example. And if you see here, what has happened is that you have started from symptoms, then you went to science, then you went to investigations, and then you went to diagnosis. So that is the approach to write a good quality. And on an average, what all you should be including: the age, gender, site of the care, primary center, office, college, tertiary care hospital, presenting complaints, duration, some additional history. This is the basic minimum which you need to provide. And you can frame a question. But if you want to go beyond that, you could also think of physical findings or diagnostic studies or response to initial treatment and so on, depending on what is your purpose and what is your objective of writing that question. Sometimes you can use templates, and these templates are freely available. If you Google Case and Swanson, 1998, they have provided templates for almost every subject, for anatomy, physiology, biochemistry, pathology. Basic templates are given. All that you need to do is to fill in the blanks, and your scenario is ready. So, A, describe the patient, 20 years old, male, working in such and such situation, is unable to describe what is the disability, get up while he is sitting, but he is able to sit down comfortably, and so on. Which of the following is the most likely diagnosis in this case? So this is just one example of a very simple template. And you have templates available for all subjects. So you can pick up your subject template, fill in the gaps, and you have a vignette ready. As an additional input, show it to your clinical colleagues. Not that they'll criticize it, not that they'll turn you down, but simply because they might provide you the clinical perspective that actually happens in those cases. And using the same scenario, same template. Now this is what has been created. So A, and then you have given a patient description, and then you have unable to, so then you have given to this, and then which of the following is most likely diagnosis. These are some other examples. So you could talk about injury, so orthopedic surgery. You describe a patient, describe the injury, ask questions about what is affected, what is involved. You could describe some disease process, diabetic, for example, high ketone levels. So which of the drugs is likely to have resulted in this kind of scenario? Or sometimes you can give a patient with some abnormal findings, and then which additional findings would suggest diagnosis of disease one versus the second. So these are some of the examples which are easily available and which can easily be used and modified to create good quality vignettes for your subject area. Some other examples, I won't go into too much or too many details of these. You can actually Google them and then look at what all you can use. Second thing which you can do is to convert simple questions to vignette-based questions. So you get a MCQ book from market, maybe pick up a simple recall type of question, and then you can convert it into a good quality scenario based. For example, if this is the question, which area is supplied blood by the posterior and inferior cerebral artery, convert it into a scenario. So basically, your answer will remain the same. You are asking the same thing from the student. Only thing you are doing is that here it was a pure recall. Here it is application knowledge. Coming to the step, it should be a complete description of the problem or the case that you want to include. Just a little break here. I understand that we have crossed 1 hour. So please let me know if you are okay with continuing or you want me to stop here. Okay. Yeah, primarily, I'm asking the PhD students because it's for them basically. So another 30 minutes or so I would take to complete the presentation. Now, one of the very good strategies in writing the STEM is to include all that you need to tell the student into the STEM. You remember the problem I told you with the correct answer is that you try to make it so correct that it starts looking obvious. No, rather than putting all the details into the correct answer, you put all the details into the STEM. Give you some examples. Now that what it does, now those correct options are applicable to all the four options that you have given. And so you take away one very potent guessing mechanism from the student. So you include all the information that the student is required to answer the question, which should basically be application rather than recall. Focus on important area, not on the trivia. And actually, these are the things which you would find me repeatedly emphasizing. Because quality actually depends on these simple things rather than some very complicated writing mechanism. Most of the time, it is not. Mostly, it is because of simple things being overlooked that actually create a lot of problem. And now, I introduce you to one very useful technique. I described it to you earlier when I told you, you write the STEM, ask your colleagues to provide you an answer. Something like that, if you don't want to go to your colleagues, it is what is called cover the option test. So you write a MCQ, put your palm on the options and see if this question can be answered without looking at the options. And there's another thing which maybe you can say I have invented, and that is cover the STEM test. I'll give you examples of those. The options should be logical, grammatically consistent, plausible, organized in logical or alphabetical manner. Avoid using none of the above, all of the above. Avoid repeating phrases across options and avoid repeating terms used in the STEM. So these are some things which will provide a clue to the student to make a guess even without knowing the correct answer. Now, in every question, you can have, and this is, for example, related to pharmacology, you can have options which might be asking about indications or dose or toxic effects or interactions. Now, the key concept is to align all your options to the same thing. Don't write a question where correct answer is indication, a distractor is about the dose, second distractor is about the side effects, third distractor is about interaction. That is not the purpose. The purpose is to pick correct choice out of either indications or dose or toxic, whatever you want to test through that question. And even in the options, I said we are talking of one best answer. We are not talking of correct answer. So one option, for example, B would be the most likely. And then there would be others which are less likely, slightly less likely, even less likely, and least likely. And longer the distance between most likely and the next correct answer, the better is the question because it doesn't confuse the student. If, for example, your B is here and A was lying here, then the students will have a lot of problems. And then it would be testing the ability to avoid confusion rather than testing the ability to interpret information. From where distractors come? Your own teaching experience. When you're taking a class, you're asking a question, short answer question, students are giving you an answer, and it's a wrong answer. That's a very good distractor. Often what we do, we frame the distractors ourselves. We think that this is the misconception the students have, which may not be true. They may know it very well, but their misconception might lie with something else. So try getting their point of view. What do they think as the wrong answer? And these distractors should appear plausible to the low ability students not to the higher ability. And more plausible they are, more attractive they are. So, for example, between typhoid and hepatitis, there will be a lot of similarity, and it requires some kind of additional knowledge to distinguish between the clinical features of enteric fever and hepatitis. But to keep one option as typhoid and another option as upper respiratory tract infection, that's actually defeating the whole purpose. And obviously, you have to avoid coming too close to the correct answer. Let me tell you, the quality of your MCQ depends on the quality of your distractor. It doesn't depend on the key. It doesn't depend on the stem. It depends only on the quality of your distractor. How much your distractor is able to attract a lower ability student actually decides, because in that case, the more lower ability students are attracted towards wrong options, your task of knowing which student knows and which student doesn't know actually becomes easier and simpler. Now, all of the above, none of the above, we see very often and very common. There are a lot of issues with these two. One, excuse me, one that you cannot put them on a longitudinal continuum. Once the patient has come to you, you have given a history, and your diagnosis is typhoid, hepatitis, cholecystitis. You can't say none of them, because that doesn't gel with the diagnosis. NOTA has been found to decrease item discrimination. The whole purpose of MCQ is actually discrimination between good and not so good students. Also decrease reliability. And they actually measure constructs like guessing, what in educational language we call construct irrelevant variance. So you are testing something different, not the knowledge of the student. So keep that in mind. Take, for example, this question. The dose of BCG vaccine is given. None of the above is the correct answer. Now, suppose the student makes a guesswork and puts that none of the above is the correct answer. He'll get a mark. But this does not tell you that the student actually knows what is the correct dose of BCG vaccine. Now, that's a problem with the note. However, there are certain situations, practical situations, where you can use NOTA. And what are those? Situations wherever a student is required to make some calculations. No guesswork. So in this particular example, he'll have to see, okay, so 100 ml per kg and 2-year child 12 kg. So it should be 1200 ml, which is not there. So none of them. That may be acceptable. But if there was no calculation required and then I had put none of the above, then probably it would be a wrong type of question to be put there and to be asked. Now I told you about cover the option test. And that's in fact one of the first things that you should do when you get an MCQ from your departmental colleagues. The first thing you should do is to cover the options and see if you can answer that question. If you read this question, can you answer this question without knowing what are the options? I realize that many of you are not from actually medical discipline, so there may be some issues. But given the information, the kind of information that has been provided, in fact, it is very easy to answer this question without even looking at what are the options. This is called cover the option test. And this is the first quality parameter that you should actually be looking for whenever you get a new question. The second comes cover the STEM test. What do you say about this question? So even if you delete all that information, you can still answer this question. So remember that sequence, you get the information, you process that information, then you come out with the correct answer. So you have actually taken away the middle part. So now it's just a recall type of question where you have added something as a window dressing, so that your boss will say, oh, very good scenario. But is that scenario being used for answering the question? No. So cover the STEM test also becomes important, especially in our setting when we are only beginning to write the scenario based or case based MCQs. This becomes extremely important. I've seen many questions, many questions, where you just remove the STEM, still the question is answered because the question lies in the last line and the four options. There's just no connection with the scenario that has been provided. Take at this example. What was the function of the vignette? So that the student can analyze, interpret, come to a conclusion, and then answer the question. You have already given a diagnosis of anterior wall MI. So I wonder what was the purpose of, giving all this history and ECG findings and examination and so on. You could have straight away said a 50-year-old man came to the primary health center with anterior wall myocardial infarction. What will you do? It would have been simpler, easier, taken less time, confuse the student less. So don't make a vignette or a scenario just for the heck of it. I've been told that in some departments, it's a practice that you should not ask the student to make a diagnosis. You give the diagnosis. If you're giving the diagnosis, then why are you writing the story? You can straight away give the diagnosis. There's another interesting thing in this question, which one that you remove the unnecessary, quote and unquote, unnecessary information, and you can still answer this kind of question. And whatever is omitted, make a diagnosis based on information provided. Second, can you guess the correct answer? There is no story. Not even a question. Okay, one that B is the longest answer, so it has to be the correct answer. Okay, that is one. But there are other clues also, and very interesting. The number of times a word has been used gives a clue to correct answer. For example, high flow oxygen, high flow oxygen. Okay. Aspirin 300, clopidogrel 600, 300, 600. So which are the unlikely options? Refer the patient to higher center immediately. Give high flow oxygen and refer the patient to higher center actually become unlikely. Now this send home is coming only once. Refer the patient to higher center immediately becomes unlikely. High flow oxygen, unlikely. So what you are left with? Anyway, three options. And this can be a very interesting time pass. Why I say time pass? Because I collect MCQ books and try to guess an answer without reading the question. And I'm correct at least 70 to 75% of the times. If you can do that, then why write MCQs? Why not simply give these options and ask the students to come out with? And all these things are actually I learned from net only. How can you eliminate questions and how can you eliminate the wrong answers. Okay, so I think, okay, just one more example, that in this, the same question, what you have done is this has become longer because you had to put all the things into it. So if you take high flow oxygen above, so how will you manage what will be the next step in management after giving oxygen? Second is aspirin. So what will be the management after giving high flow oxygen and 300 milligrams of aspirin? Same way, higher center. So what will you do before referring the patient to a higher center? So what you are left with, only one choice, that is clopidogrel. You can now think of different kind of distractors. So shifting all the things, and of course, please cut down the diagnosis, because if you are giving the diagnosis, then the whole purpose of using a vignette is lost. Then simply we are wasting our time, students' time, everybody's time. So I'll end here and open to any questions that you have. We'll try to answer those.
ये थ्योरी में जो लॉन्ग क्वेश्चन आता है ना अभी सीबीएमई में उसमें वो अर्लियर हम डायग्नोसिस नहीं लिख रहे थे तो वो कहते हैं कि अगर बच्चों को डायग्नोसिस नहीं पता तो 10 नंबर गए उसके तो उसने अगर रॉन्ग डायग्नोसिस बना लिया तो मेरे को स्पेशली कहा गया कि नहीं आप ऐसे ध्यान रखो भी वो रॉन्ग डायग्नोसिस गलत हो गया उसको बच्चे को पता था 10 नंबर पे गए ऐसे तो डायग्नोसिस नहीं रिटर्न
See, you are very right. In my opinion, competency actually starts by making a correct diagnosis. You may know everything about drug A, you may know everything about investigations, you may know everything about communication and skills and procedures and etc. etc. But if your diagnosis is wrong, then everything is wrong. So competence actually begins with making a correct diagnosis, and that's the crux of the matter. So same way for MCQs, if you are already supplying a ready-made diagnosis, then you are actually taking away the ability of the question to stimulate the student to think about making a correct diagnosis. Please avoid giving a direct diagnosis unless it has a relation. When you say he was diagnosed MI outside, but the following investigations were done, and so what differential diagnosis will you like to give? If you are putting it like this, then yes, it may be okay.
Sir, I think you're talking about modified exam. Modified exam.
देखो जैसे मैं पर पैथोलॉजी में क्वेश्चन आया इसमें वही आंसर उसका स्टूडेंट डायग्नोसिस नहीं बना पाया स्टूडेंट ने कुछ और ही डायग्नोसिस बना दिया व्हिच वाज रॉन्ग तो टोटली रॉन्ग बट
फिर उसके बारे में सही लिखा हो
पर हाँ जो डायग्नोसिस उन्होंने बनाया उसके बारे में आंसर सही लिखा हुआ
No, see, that was the older way of thinking. When I was sometimes taking Viva and you ask something, they'll give you a wrong diagnosis. Uski treatment, they'll very rightly tell, and then your co-examiner will tell you, "Chalo, wo nahi aaya, wo to aata hai na usko." But in practice, that doesn't happen. Na? When a patient comes with typhoid and you start treating for malaria, although correctly you might give the doses, that doesn't help. You have to first make a correct diagnosis, and that is the beginning of competence. Without making a correct diagnosis, there can be no CDM. And I think we should be very clear on that part. So if he has not told you about the actual diagnosis, howsoever correct and latest information he may provide for a wrong diagnosis, it cannot substitute the right diagnosis.
Good morning, sir.
Good morning, sir. But I have a different, sir, question. I mean, on similar lines. I am a pharmacologist. I don't teach them how to diagnose the student, the disease. But as a teacher, I only teach them how to treat the disease. So in my question, and the CBL question, case-based question, can I ask the question, okay, what is the diagnosis in this case?
Sure, why not? See,
So because this is not,
Gurleen, after all drugs have to be given after first making a diagnosis.
yes, sir.
Let's remember that. You know, you
Yes.
cannot prescribe a
if-
medication without making a diagnosis.
Even if my incompetency pharmacology doesn't improve the diagnosis, even then.
So at some point of time, I gave you the examples in the, I think you missed some of the first few
Yes.
slides where I said that simple recall type of questions or conventional questions can be used to assess the efficacy of your teaching.
Yes, sir.
They can also be used to stimulate the student to read more about that. So you can use those type of questions where you already provide the diagnosis. But in that
So
case,
is it right?
please take this take this question for example. You might simply say anterior valve MI was diagnosed. Now, why you have to provide about ECG and ST elevation and T depression? That is not required. No? You are unnecessarily wasting everybody's time.
Yes.
So if you had simply asked, let me go back. So if you had, for example, simply asked that a patient got to a primary health center with a diagnosis of acute MI, which of the following should be done? It was good enough. We are putting effort without getting a advantage in return. And I repeat my earlier assertion that the purpose of teaching a medical student is actually to make him a clinician. Let's accept that.
Yes.
We
Yes.
are not teaching him to
So
make a
even if my
pharmacologist or physiologist.
competence, even if as a pharmacologist, my competency was not to make him perfect in diagnosis, but even then I can ask the question that
You
what
can,
is the definition? What is
surely,
the
yes. Yeah, otherwise, if you don't ask questions related to your subject, then how will you assess your own subject?
Yes.
While I say that we are trying to make a complete physician, the fact still remains is that we are doing a discipline-based, subject-based teaching. So he has to pass in your subject also. No? So you have to ask questions on that. No two views. But my point is that why not then simple, straightforward questions related to what you are trying to ask rather than confusing the student and taking him through all this labyrinth of information which is not at all required for giving the answer. So actually speaking, a student can ignore all this information. You could not have written all this information, yet your question was complete. So that is the point I'm trying to make. I mean, it's not like, uh, pardon me for saying so, but they generally say that medical education, like ladies' shoes, is governed by dictates of fashion. So let's not do it because it is fashionable to do so. We should be doing it only for the educational utility of it. If something is useful educationally, yes, do it by all means. But simply because MCI says write scenario based or somebody else says write scenario based, therefore we are writing. I'm sure in this only you could have created, I mean, you means the question writer could have created a scenario where it was related entirely to the drugs.
Yes.
That a patient was diagnosed as MI and he was given this medication, it didn't improve, and then he was done this. Know what medication you will give. So, you could have done that. So, you are using a medicine scenario, asking basic pharmacology questions, and not gaining anything out of the long information that you have provided. That is my point. Of course, you have to assess your subject. And don't take it this way that you will not assess pharmacology or you will not assess pathology or any other department. Okay. Any other question?
Sir, hello.
Ah.
Sir, I am Dr. I am a professor in forensic medicine. Sir, I have gone through the writing vignettes. Under this, you told that from the symptom to the diagnosis, then treatment, we should proceed. And we should not reverse. Here, actually, I disagree. Why? Because this is also a type of test of the mind, uh, asking something to test from in the reversal. It's usual question. My point is, in some instances, we may intentionally want to know the means starting by providing the end. Some mathematical solutions are also being done in this way. I was a examiner for, I was preparing MCQs for the PG post-graduation test in Ethiopia. We were told not to go outside and not to share anything. We are kept in a one room for 2 days long. Lot of things actually, what you told here, they were making it restricted. Today, you told even there was a chance of using nota or all of above there. So it depends on you. Too much of restricting without knowing the basics also is not good in my opinion. So overall, we must learn these things. But while preparing the question, we should have the freedom to be very specific on testing the student. This is what actually I want to say.
I take your point, but I stand with my assertion that your assessment has to follow what the students are actually going to do in real life. And in real life,
Okay.
what they would do is to begin with history and findings and go to diagnosis rather than going the reverse way around, first knowing the diagnosis and then going to history and findings. You can frame an interesting question, what you can give a diagnosis and then ask which other findings you think the exam
Yeah.
doctor missed, which could have helped. You could do that. It requires a lot of ingenuity to actually come out with different kind of questions. So what I am giving you in this talk are the general guidelines,
Yes,
which
sir. Yes.
one needs to keep in mind. So you can have a reverse process, but don't use it as a routine.
Yeah.
Once in
Very
a
good.
while, when you
Very.
have some
Yes.
peculiar situation, you you may write a reverse question. That is okay. But then, if every question starts like that the diagnosis is this, now you tell me what to do, then I suppose there is going to be a
Yeah.
problem.
Yes, sir.
Okay,
Your
thank you, sir.
presentation is very good and acceptable also. Very.
Okay, thank you, sir. Any other inputs?
Sir, this is a very nice, wonderful session. We really enjoyed each and every slide. Everything was totally, absolutely very nice, sir. Very nice informations. I have a query like, sir, what about the time that has to be, suppose if we include it in our formative or even summative assessment, how much time should we allot for answering, sir?
In our
Usually
traditional form, in
it
our
is 1
traditional
minute.
format,
Yes, yes.
in traditional format, we are giving 180 minutes for 200 questions.
Okay, sir.
That is the general format we follow. So the
Yes.
time allotted for each question comes to a little less than 1 minute,
Yes, yes.
about 0.8 or 0.7 minutes. Now, when you are giving a simple recall type of question like mandibular nerve is, then this may be enough, more than enough. But if you are giving a question like this, then the student has to read. And if your writing is not clear, sometimes we can add unnecessary information. Sometimes we can add information which is not really required in a particular case. Then the students needs even more time.
Yes.
So on 3 hours, 200 questions format are not supportive of this kind of an examination. So for these, you have to give a longer period of time. In USMLE examination, for example, where majority of the questions are like this, they don't have a simple recall type of questions, then the average time that a student gets is not less than 2 minutes per question. You can always make your choice. In formative assessment or internal assessment, there's no problem. You can always give more time, 4 minutes, 5 minutes also, no issues. But when it comes to summative and NEET and next and those kind of examinations, then you may have problem with these kind of questions. So the time has to be increased. And I believe in next, they have actually made it a whole day test by having morning session and evening session so that the student gets actually more time to answer these kind of questions.
Okay, sir. Thank you, sir. Sir, the next question doubt I have is about, you said the MCQ should not confuse, should not create confusion. But my query is, when we face the real world situations, the clinical cases, patients, is there not a confusion that we face, sir, actually, as a beginner? So confusion must not be there. Is it a dictum,
Confusion
sir?
is part of life. You know? Yes, confusion is part of life, more so in medical practice, because things are generally not that clear. When I say don't create confusion, you are deliberately trying to confuse the student. That's what I request you to avoid.
Okay,
You know,
sir.
some confusion will always be there, whether it is typhoid or hepatitis. That is a confusion that will always be there, even in real life practice. But what I am trying to say is that when you are describing features of a patient with typhoid, don't add serum bilirubin level is 8 milligrams per
Oh,
cent. That's deliberately confusing the student. So
okay.
avoid that.
Okay, sir. Thank you, sir. So finally, sir, you were mentioning a quote. I didn't get it. So please, would you repeat it? Medical education is like a lady's shoe, something you said, sir.
Please choose, yes.
Why,
You
sir?
agree with the quote? You agree
No,
with
I
it or
don't
no?
get I don't get it, sir. In what perspective?
So you could replace shoes with dress, I suppose. Then. Like ladies' dress, it is governed by dictates of fashion. So sometimes we have a problem-based learning, sometimes we have a community-based learning, sometimes we have a competency-based learning, and next might be something again a new phenomenon.
So we need to change it frequently.
So
Okay.
I suppose we are already 40 minutes beyond the time, so we'll end here because
Okay.
after that we have another class to follow. So thank you very much for being with us. And if you still have any problems or doubt or questions, feel free to send me an email and I'll be happy to answer.
Thank you so much, sir. Thank you.
Thank you so much.